Everybody, I think we should get started. Sorry for the delay. We had another meeting that went over a little bit, so we'll try to make up for time. I'll just talk really quickly. That should be it. Okay, I want to welcome you to the Enforcement Committee of the Medical Board of California. I'm Dr. Ronald Lewis. I'm chair of this committee. I want to ask all of us to turn off our cell phones to silent, and for board members, cell phones should probably be off the table. They tend to create some interference. You may notice that many of the board members have their laptop computers here at this meeting. The reason for that is that they're accessing material on the little zip drive instead of people like me who are old-fashioned that carry it in paper. So that's the reason why they have their computers up. This is an official business of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have a designated time on the agenda for public comment, and we will be asking for public comment on each and every agenda item. I ask that you be respectful of the need for us to conduct the board's business. Should anyone disrupt the meeting, I will ask that person to conduct him or herself in such a manner that permits the board to transact its business. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. And if for some reason I'm remiss and I forget to ask for public comment, please raise your hand and remind me, and you will be recognized. I would like to remind all speakers to complete a speaker's presenter's slip, so I can call you by name at the appropriate time on the agenda item, and we can record your name as a full and complete record for this meeting. Please give the speaker slips to Ms. Romero. Ms. Romero, could you appear? And she will take your slips during the meeting. The meeting will be available by teleconference, and individuals listening to this meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating by teleconference, please wait until the moderator has introduced you before you make your comments. There tends to be a little lag time, so to request to make a comment during the public comment period, press the star 1, you will hear a tone indicating that you are in a queue for comment. If you decide that you no longer want to make a comment, press the pound sign, and that'll remove you from the queue. Please remember to mute the volume on your screen during your presentation because it'll avoid the feedback. Assistance is available throughout the teleconference meeting. To request a specialist, press star 0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the board has limited the public comment period for individuals on the teleconference and those present here today to 20 minutes. Therefore, after 20 minutes, no further comments will be entertained. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be entertained. Please see Vang, who will be assisting me with receiving the public comments via teleconference during this meeting. So you'll hear C. Vang on the phone if there's any technical difficulties to try to assist you. I'll do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make a last-minute comment, but we need to ask you to please fill out a speaker slip after your comments so we have it for the official record. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to end today at 12:30, and therefore we may take some items out of order to accommodate this schedule. I would like to call the meeting to order now and ask Ms. Romero to please call the roll. Ms. Romero, the roll, please.
Dr. Kraus?
Here.
Mr. Liu? Here.
Ms. Shipsky? Mr. Serrano-Sewell?
Present.
Ms. Yaroslavsky?
Present.
Dr. Yip? And Dr. Lewis?
Present.
We have a quorum.
Thank you very much. On agenda item 2 on your agenda sheet, I have the following. I have no speaker slip for agenda item number 2. And is there anybody on the phone? Mr. Vang? This is for public comment items not on the agenda. Ms. Romero, do you have any for that?
We
Okay.
have no callers in queue.
No okay, very good. Thank you very much. Agenda item 3, approval of minutes from the May 1st, 2014 meeting. Thank you.
So moved. Second.
Second. Is there any public comment from those in the audience or on the phone? Mr. Vang?
Yes, we do have a comment.
Okay.
Dr. Kadisha Lang with the National Medical Association. Please go ahead.
Okay, Dr. Lang, go ahead.
Dr. Lang, your line is open.
Okay, go ahead. We're ready for your comment, Dr. Lang.
Are you able to hear me now? Can you hear me now?
Yes.
Yes, we can hear you.
Can you hear me?
Yes, we can hear you. Go ahead.
Okay, thank you. I'm Dr. Kadisha Lang. I'm the Vice Chair of Region 6, encompassing the 14 westernmost states, including California, of the National Medical Association, which represents the concerns of the nation's 50,000 African-American physicians and physicians of African descent, as well as their patients' well-being. I thank you for allowing me to once again address this board regarding issues that our members expressed. Firstly, there is a long-standing and persisting perception in the African-American medical community that the Medical Board of California has a negative bias towards them in its decisions. Our physicians repeatedly find themselves receiving longer, harsher penalties for accusations lodged against them as compared to non-African-American physicians facing the same or very similar allegations. The first assumption one might make is that, well, they shouldn't do anything wrong and they won't be in that situation to begin with. It is important, I believe, that this body realize how the board's process works and affects us differently, because statistics clearly demonstrate that the average African-American doctor makes significantly less money than their non-white colleagues, than their non-African-American physician colleagues, due to opening practices in medically underserved areas that have disproportionate percentages of patients on government assistance and Medicaid or Medi-Cal. Their profit margins often don't allow them the choice of hiring adequate legal representation to give them a fair defense once charges have been lodged, whether they are based or baseless. And this often causes them to be forced into settling on accusations that they are not guilty of due to the exorbitant cost of defense preventing them from being able to mount one. Were they choosing to not accept government-sponsored medical insurances, they would have a much larger profit margin and be able to hire appropriate legal representation to properly defend them against charges when those charges are false or baseless. But when a physician who has a very limited profit margin is facing charges that require a minimum of $50,000 from attorneys for retainers to begin representation, they're often forced to make a decision that, well, it's better to settle and still have a license to practice somewhat, so it would be restricted for life, than to go there and try to fight it myself without proper representation, and because of lack of knowledge of legal procedures, end up losing everything. And I think it's very important that people understand how this process works. Getting legal representation is only the first hurdle that physicians often face if they are operating small solo practices with minimal amounts of excess cash or savings, because they have opted to work in medically underserved areas and serve that community. It actually becomes a double punitive.
Dr. Lang, your time is up.
I'm sorry,
Your time is up.
I could not understand the comment.
The time, you've exceeded your time limit. You're on, talking about, I believe, agenda item number 9, which you were having later,
Let me
so.
just quickly summarize with 2 more sentences. Thank you.
Okay, go ahead.
The point that we'd like to bring forward is that we think it's important for us to recognize the disproportionate impact on the African American medical community when their physicians are limited in their ability to practice or removed, because that community has such a small number of physicians in the first place. Capitation rates are often in some communities 1 to 4,500, 1 physician to 4,500, up to 6,000 patients, versus 1 physician for 900 to 1,000 physicians in many suburban areas. So removing 1 physician from those communities has a much more significant effect and impact on a community's health. And lastly, the medical board has a gender diversity issue that is sorely lacking in representation in at least 2 areas: African American physicians and physicians in general practice. There's only 1 pediatrician and multiple surgeons or surgical specialists, but no family practice or internist on the board, and their perspective is very important to the average citizen medical consumer.
Dr. Lang,
Bringing more of them.
you have exceeded your time, Dr. Lang.
Okay, thank you very much, Dr. Lang, for your comments, and the staff note that is under agenda item number 9. So if you can
I'm
make
sorry,
that.
I'm not understanding what you're saying.
That's all right. So we appreciate your comments, Dr. Lang. We're moving on to our next agenda item, but thank you very much for those comments, okay? Okay, let's go back to agenda item 3, which is the approval of minutes. We heard a motion to approve and a second. All in favor?
Aye.
Opposed? Okay, the motion passes. The minutes of the May 1st, 2014 meeting have been approved. We go on to agenda item number 4, discussion and consideration of the pain management expert reviewer policy by Deputy Attorney General Jane Zach-Simon and Kimberly Kirschmeyer, Executive Director of the Medical Board of California. Ms. Zach-Simon and Ms. Kirschmeyer, I'll welcome you to the speaker's table.
Good morning. Good morning. I would like to introduce Jane Zach-Simon. Ms. Zach-Simon was recently promoted as a supervising deputy attorney general in the San Francisco Attorney General's office. This office now has 2 supervising deputies. As most of you know, Jose Guerrero is the other deputy, supervising deputy in that office. Ms. Jane Zach-Simon has been handling medical board cases for 22 years, and she would really be considered an expert on our cases, specifically those alleging inappropriate recommendations of marijuana and also pain management cases. Ms. Zach-Simon was here when the issue of experts for pain management cases was actually originally discussed with the board, and I'm glad she could be here today to present this issue with me. Please direct your attention to your packet on pages ENF 4-1 to 4-4. As outlined in these memos, today we are seeking the board's approval to change the current policy for expert reviewers in pain management cases. Ms. Simon will provide the background and reason for this request.
Good morning. When we started talking about this issue a couple of months ago, it was hard to believe that we were back to an issue that came into effect. I think we had a task force that started in about 2000. And I remember Mrs. Yaroslavsky participating in the discussions, and another deputy and I were traded off going to task force meetings. And this was around the time when the board revised its guidelines for prescribing for, I think the term at that time was intractable pain. And some of the terminology has changed, but the issues are still there about what do we do to make sure that doctors are treating pain adequately, but also treating it appropriately and within the standard of practice. And there's always, no matter what you do and how many guidelines you have, that's an ongoing debate and a subject that I'm sure we will be back on in another 10 or 12 years. But one of the things that came up in the early 2000s was that pain management was really emerging as a separate and concrete subspecialty. But at the same time, all doctors were under increasing expectation that how do we treat patients with pain? Some of us have patients that we have been treating for a long time, and we do treat them, and maybe they don't need to go to a specialist at this point, but doctors were very nervous about providing adequate treatment for pain, and we were, from the medical board's perspective, we were still emerging from the age where we handled pain cases by counting pills and counting milligrams. So in an effort, when the board revised its guidelines, I think in 2003 or so, we also agreed that it would be a good idea to make sure that non-pain specialists had some room to treat their patients without fearing that they were going to be subject of a medical board investigation and disciplinary process, and being held to a standard of somebody who really was maybe even board certified in the area of pain management, but who was very highly trained. And all of this discussion coincided with a statute that required all physicians to obtain continuing medical education in the area of pain treatment as well. So the expectation was that this was, the board adopted its policy where pain management cases are reviewed by two different experts. They're reviewed by an expert in the field of pain management, and they're also reviewed by an expert in the field of the physician who's under investigation. And that seemed like a good compromise at the time and a good policy that would allow patients to be treated and doctors to the freedom to treat while they were learning and getting the expertise necessary. But at the time, that was never intended to be a permanent policy, and it's some 12 years later, and we're still working under this cumbersome process where every pain management case that doesn't involve a pain specialist has to be reviewed by two experts in two different disciplines. And it's a costly and time-consuming process from an investigative perspective, and it is also a difficult legal situation because you have sometimes experts who are speaking essentially two different languages. And we believe that we've just come to the point where this policy has outlived the purpose for which it was created and has caused a lot more problems, and that we really are at the point in pain medicine where people who are treating patients for chronic pain, we're not talking about an emergency room visit or a patient who has a broken leg and needs pain medication to get through a period of acute pain, but physicians who are treating patients for chronic or intractable pain really need to be held to a standard of a physician who knows what he or she is doing in that area. And it's, we believe, time to start treating pain cases the same as we treat all other cases that are under investigation. And I did, in my memo, I did include a few examples. But if we have a physician who's treating let's say we have an obstetrician who decides to do cosmetic surgery, we would evaluate the case according to the standard of practice for a physician who performs cosmetic surgery. And there really is no longer any reason to treat pain cases differently than how we treat other cases.
Ms. Kirchmeier, do you have an additional
Well, I just wanted
comment?
to say, so what we're asking for today is really just a change in that policy. As Ms. Zach Simon pointed out, we are treating these cases differently, and we do believe that we need to move on to where we actually have these cases only reviewed by one expert, and that expert would be in pain management, individual who's trained in that, and that would be very similar to how we treat all of our other cases.
Okay, so what, I've heard is there a motion to approve the change in expert reviewer policy to just require one expert reviewer?
So moved.
Okay, is there a second? Okay. Is there any public comment from those in the audience? And I have one speaker slip from Ms. Yvonne Chang from the CMA. Ms. Chang, you want to come please to the speakers table? Thank you.
Good morning. My name is Yvonne Chung. I'm with the California Medical Association. Thank you for allowing us to speak on this issue. We have some concerns with the proposed change. In discussing this issue with some of our physicians, going to just one reviewer who is a pain specialist, they believe sort of implies that only pain specialists should be managing pain. And I understand that this policy is limited to chronic pain. We're not talking about a broken arm, but it does raise some concerns because, as you know, the number of board-certified pain specialists is relatively small. So you do have a relatively small pool of them who would be available. Second, we have a lot of internal medicine physicians who would not be who would not be board certified in pain medicine, but they do treat pain in their regular practice. We have physicians who are providing palliative care, or geriatricians who are regularly providing pain management, but again are not pain specialists, and they have some concerns about being evaluated by someone who only does pain. And so our point is that the context is important. We do appreciate that having two different medical opinions can be very difficult, but I don't think that's a reason to discard one of them. You'll find this not just in pain, but in all kinds of specialties where you'll have difference of opinion, between, say, in pediatrics, you'll have a pediatrician and a pediatric subspecialist, and they may have a difference of opinion, but I think we need to figure out a way to make that work rather than just discarding one of them. And finally, I think this is an important enough change, and given the board's current work in revising the prescribing guidelines, I think if it is time to relook at the policy, this may be something the board may want to consider opening up to a stakeholder meeting, because as you saw with the prescribing guidelines, there was a lot of input. The pain community is not unified on this issue, so I think it would be certainly helpful to get some more information and perhaps change other parts of the policy too, rather than just changing a number in the existing policy. Thank you.
Okay, thank you, Ms. Chung. Appreciate it. Any other public comments from those in the audience? Any other speaker slips? No. Mr. Vang, are there any comments from those on the teleconference?
No callers in queue.
No callers in queue.
Dr. Lewis?
And then now we go to comments from the members of the committee.
So I would like a point of clarification. You okay there?
Yes, I am.
Point of clarification. I understood from the opening remarks that the object was that if it was a pain specialty doctor that was being investigated, a pain specialty expert would be reviewing the case. But if it was a regular, non-specific pain doctor, that the specialty that the doctor was in would be evaluating. And then I heard at the last sentence the reverse, and then I'm reading in the statement in Ms. Sack-Simon's report that your office is recommending the policy be revised to eliminate the two experts, which I agree with. Like in all other cases, require only that pain management cases be reviewed by experts in that specialty. So I'm not sure, and I'm not clear what you're requesting, because I would suggest that doctors that are prescribing medications for pain that are not pain specialty doctors should be reviewed by their own. Well, let's hear where you're going.
Under the current policy, the normal practice is that we have two different experts in pain cases, but if you have a pain specialist, for example, that the board is investigating, somebody who is board certified in pain medication or that is their specialty, they will only be reviewed under the current policy by one expert, and that would be a pain specialist, because that is their specialty. We don't need to have two different pain specialists. The change that we're requesting in the policy is that all pain management cases be reviewed by a pain management expert.
So that's the clarification I would like to hear, is that a doctor that is a non-patient pain specialty that is prescribing medication, and one of the issues of the investigation goes to prescribing, that doctor, regardless of specialty, would only be investigated by a pain specialist professional.
Correct.
And I
that
have
is that's just the same way we do with all of our other cases. So if we had a individual who was doing obstetrics, let's say he was board certified in OB-GYN, and he went outside and he did a cosmetic surgery case, we're going to have an expert in cosmetic surgery. This is the same way civil cases are done. They go to the individual in what that practice and what that treatment was provided to that patient. That's the way we do with all of our other cases.
But if the OB-GYN doctor was being investigated for OB-GYN practice, you would have an OB-GYN expert.
Yes.
So as part of the treatment plan of a doctor that is not a pain specialty doctor, I'm not clear as to why you would need to use pain specialty as the expert versus his own within or her own profession, an expert in that profession. I understand the one doctor. I'm no problem with the one doctor expert review. What I have questions about is to why a pain specialty doctor versus a specialty doctor in the profession that doctor is to start with.
Because at that point, he's no longer practicing his internal medicine. He's practicing as a pain management physician in that regard.
Could I move on to other comments? Dr. Kraus.
Thank you. I'm sympathetic with Board Member Yaroslavsky's comments. And it's interesting that this issue comes to us because pain management is now a part of every medical school curriculum for all specialties, and all of us, including ophthalmologists like me, had to do our 12 hours of pain management. So on the one hand, we're saying now that pain management training is ubiquitous, we no longer need two experts. But on the other hand, we're saying an ophthalmologist may not be the appropriate one to evaluate me for my skills in pain management. There's some inherent contradiction there. So I would agree with Ms. Yaroslavsky's comment that if we want to make the process more efficient, that perhaps it's appropriate to have a like specialist in this circumstance review the case, because we're all skilled in pain management now. And if indeed another ophthalmologist would say Dr. Kraus was inappropriate because he was treating a patient with metastatic cancer for chronic pain instead of referring that for pain management, then that would be a reasonable criticism on the part of another ophthalmologist. But my main concern is that in medicine, I have observed that doctors, like all other people, may have biases. And regularly I see legislation introduced. Radiologists say that other physicians other than radiologists should not have radiologic equipment in their office. Board-certified plastic surgeons say no one other than a board-certified plastic surgeon should be doing cosmetic procedures. So specifically in a pain management specialty, where we don't have a plethora of pain management specialists, and there may be some bias, I would be a little bit reluctant to say that the one expert should be a pain management physician in this case, rather than to say a like specialist.
I'm also going to echo my two committee members' comments, is that we know now that the pain is the fifth vital sign, and so all physicians are responsible to assessing their patients' pain and pain control. And in a world where we do not, as Dr. Kraus said, have a lot of pain management specialists to go to, and especially some of the rural areas where there's maybe one in a major city, that we're now telling through this policy is that maybe I better not touch pain management. Maybe I need to tell that patient they need to seek a referral elsewhere. So I'm under the opinion that I think we're taking this a little too far now. I would like to see this brought back a little bit. Let's think about it before we act on it, because I think we're going to shoot ourselves in the foot, and we're going to send a message out there that primary care physicians should maybe not be taking care of chronic pain, and I'm not sure we want to go that way. So those are those are my comments.
So I would also like to thank you for the comment, but I would also like to remind this committee as well as the board members is that the reason for the intractable pain discussion years and years ago was not only the overprescribing of medication, but was for the underprescribing of medication. And my concern by putting this back into a situation, it feels to me that we're going backwards, and I just want to be assured of the fact that within this discussion, that the standard of care is not going to change, that the expectation of anyone prescribing has to go follow through, even though you've got here on page 2, 4.2, you've got the standard of practice. And standard of practice to me, I just want to ensure to me that it's the standard of care. They're synonymous, that they mean the same. My concern is that they might not.
They do mean the same thing.
They mean to the legal profession? Do they mean to the medical profession? Do they mean to the public perception? Maybe it needs to be enumerated as to the good faith exam, the medical record keeping, the treatment plan, and the follow-up and reevaluation as part of that discussion, so that we're constantly reminded of what is the expectation of a doctor regardless of their profession as to what they're doing. And my concern is that we're going to cause question. So with this whole moving forward, as Dr. Lewis suggested.
So we're at a point where we have a motion on the table, as stated by Ms. Yaroslavsky. I think it's your motion?
Yes, it is.
What is the?
I don't know what the motion is. What is the motion you were asking?
Want to read the motion so we know?
I'm tired, so I apologize. So I don't
Motion
remember.
was to move to
It was moved
one
to discussion, so it's
expert. So you just
we're
want to withdraw it. But I believe Ms. Zach-Simon has one other point.
Well, our point really is that it should be one expert and not two experts in disparate specialties. If the board is not comfortable having that be a pain management specialist, then as long as it's one expert and we have cases that we can look at and analyze and assess and make decisions based on experts that are speaking the same language, I think we could manage the cases a lot better.
I'm fine with the motion as it stands.
Yes, it's the experts speaking the same language is the key point, because as Dr. Krause says, that might not be the same depending on your level of expertise and training.
So we're not willing to define the expert at this point, but we understand, I think, the importance of having one expert.
Okay. Dr. Krause?
I would like to amend the motion to require that the expert be in a like specialty.
I would accept absolutely.
Accept that amendment, okay. And that you're the seconder of that, your second, okay. Any more discussions from board members? No? Okay, so we're up to a vote. So all in favor of
You have to have public comment because you've changed the motion.
Anybody in the audience or on the phone that would like to comment now that we've changed the motion?
No callers in queue.
And no one in the audience? Okay, so then we're finished. Okay, all in favor of the motion as stated now?
Aye.
Aye. Anybody opposed? Abstentions? The motion passes. Thank you. Okay, now we're going to continue to agenda item number 5, and that's the discussion and consideration of proposed amendments to the statement on marijuana. And Ms. Kirschmeyer, please.
I'd like to direct your attention to pages ENF 5-1 to 5-3. And as stated in the memo, in 2004, the board adopted a statement clarifying that the recommendation for marijuana by physicians in their medical practice will not have any effect against their physician's license if they follow good medical practice. The board's website continues to have this 2004 statement posted. However, in reviewing this statement, board staff believe that this statement needs to be amended as some of the information is misleading and some does not comport with the current law. Throughout the entire document, including the title, is the phrase medical marijuana. Although marijuana can be recommended for medicinal purposes, the term medical marijuana is misleading as there is no such thing as medical marijuana. This is an industry term, and board staff is recommending that this be clarified throughout the entire document. In addition, one other issue with this statement, which was brought to the board's attention during an administrative hearing, is that the statement asserts that an initial examination for the condition for which marijuana is being recommended must be in person. This statement contradicts the board's telehealth law. The initial examination must follow the standard of care and must provide an appropriate prior examination. However, at this time, there is no law that requires this examination to be in person. Therefore, the board is recommending a change to the statement to comport with the law. The actual changes are listed on the pages in your packet. Unless anybody has any questions on the changes, I'd like to ask for a motion to make the changes that I identified in your packet, unless you'd like me to walk you through them.
I have questions on this
Okay, let's-
specifically, so I don't know if you want to take a motion for the purposes of discussion, or if you want to walk it through first.
Dr. Lewis.
Your
I think it's okay if you do go ahead with the discussion.
Okay.
Is this okay?
discussion. Me?
Giving you-
Yeah, oh, absolutely.
You-
So you're looking to change the term medical
Well, we'll come
marijuana.
back.
Oh, is that okay? Dr. Cross,
Yeah.
please.
We're fine. You go ahead. Yeah, we'll take the public comments. Go ahead. Continue. I'm perfectly fine with
So
it.
just for clarification, okay, perspective?
It'll be important, yeah.
The term medical marijuana, you're looking to turn and change to marijuana for medicinal use
Medical purposes, yes.
or medical purposes, is that the same?
Yes.
Okay.
And throughout the entire document, that's pretty much the edit that we're making.
And the telehealth law, would you be more specific as to what the law states, please?
Yes, basically, the law authorizes an individual to be practicing in another area as long as there's informed consent. They do not have to be face-to-face, as long as they are providing an appropriate prior examination.
So as a point of clarification on this specifically, that's where I'm going, is so that a person that is making the recommendation for the medical marijuana does not have to be the same person making the examination and the treatment plan and the follow-up and the medical record keeping can be two different people?
It could be if it was with a physician. So if you had a physician that was providing an appropriate prior exam to an individual via telehealth, whatever that may look like, and that is according to the standard of care, that could be performed. So if they were at a clinic, for example, and they had a general practitioner there who was performing, or even a nurse practitioner, and that individual was doing the examination, and they were via telemedicine to an individual who recommended marijuana, that individual could recommend the marijuana, and that other individual that was in the facility could be doing the exam.
My concern specifically here is that we are giving license to the ability for a person to walk into a building and receive a recommendation from someone who has not done an exam, has not done a treatment program, has not maintained medical records, and has not done follow-up. So I want to make sure that within the document that you're recommending here, that is not what you're recommending.
And I would like to draw your attention to ENS 5-3, because Ms. Yaroslavsky, we have that same concern. However, the way it is written, it is not according to the law, so we need to make sure that we conform with the law. So what we've changed is removing the must be in person to what our law actually says, and it must be an appropriate prior examination and meet the standard of care. So if we received a complaint about an individual who walked into a facility and saw me, who was standing there with a cash register and was telehealthing via telemedicine to a physician in another spot, and that was not an appropriate prior examination according to a standard of care. So we would send it out to an expert, and that expert would opine on whether the exam that was performed was according to the standard of care and met the prior appropriate examination. If it wasn't, then we would take action against that physician, because that's what we do with all telehealth.
I'll wait for more discussion because I'm just not sure it's tight enough.
Okay, Mr. Serrano-Sewell, you had a comment?
Thank you, Chairman. You think this proposed policy is needed to provide clarity to staff
No, I believe that this policy needs changed in order to comply with the law.
Okay.
As it currently is written, it does not comply with the law.
The statement doesn't, so
The
it needs to be.
statement does not, that it has to be in
updated.
person. It needs to be updated.
And can we just go over once again the need for the terminology, the words, medical marijuana, we're striking that, marijuana for medical purposes. It seems the same to me.
That, since we were going through and changing it, there is no such a thing as medical marijuana, and it's been brought to our attention on more than one occasion. So it's going back to the fact that it's marijuana that is recommended for medicinal or medical purposes. In that change, it's more of just a clarification rather than a comporting with law.
You're just getting people to say MMP or MMU and not marijuana for
Right, it's not medical marijuana. There is no such a thing as medical marijuana.
I've been consistent since I've been on this board.
Yeah.
It just to state again, because we're talking about a topic that I know generates discussion, that I do believe marijuana for medical purposes, or medical marijuana, however one wants to phrase it, does provide relief and care for people in pain and suffering from an illness. And so long as the physician comports with the law in giving that prescription, that should be honored. And the state should dedicate its resources to ensuring compliance with that, but it's an issue that the state struggles with, as does this board.
Dr. Kraus, please.
Alcohol has known medicinal benefit. I imagine a situation where it was unlawful to obtain alcohol without a physician recommendation, and every liquor store had a doctor sitting in the corner writing out recommendations for alcohol. We kind of dance around this with marijuana, and we're confined to the law as it is. But I would have nightmare in a circumstance knowing that all marijuana recommendations could be made by telehealth.
Exactly.
And I imagine a remote room filled with licensed physicians Skyping with people who want their marijuana recommendation, and that gives me chills. So if it is not current law that would prohibit that, then I would say that there's an obvious need for law or regulation that would prohibit that, and I would want the marijuana recommendation to be on the basis of an in-person examination until the state comes to its senses and makes this a recreational substance rather than one which can only be made available through a physician's recommendation.
So I can give you a little bit of legislative history, and I have to look to Ms. Simoes for the bill number, but there was a bill last year that was going through the process that would have required it. We had asked for, in our discussion with them, for it to say the words that it must be an in-person examination. That did not make it through the legislative process. As these bills come forward, that is something I think that this board feels very strongly about, and we will continue to try to get that put into legislation, because we agree with you, but at this point, what we have to do is as the complaints come into us, we have to take the action based on current law, and that's what we're doing, with it being outside of the standard of care.
Yes, Ms. Shifsky.
As a former member of the City Council that grappled for 8 years on medical marijuana collectives, and by the way, there is no such thing as a dispensary, and people use that as a common language. It is really important because there are right now operators who are standing by, but operators who will put a room full of people and literally Skype to a physician who will then ask how many people have pain and then write the recommendations. So this is occurring. The in-person exams are not occurring, and the record keeping isn't occurring. And by the way, cities that have these ordinances are requesting that there is documentation of some sort, but it doesn't exist. And many of the physicians are actually being used to recommend a specific strength of marijuana when they make their recommendation, and that's a commercial decision because that's what the particular store sells. So I think we do need to do cleanup language as much as possible, and we even as a nurse practitioner, I have some reluctance that if you can allow somebody, and I don't believe the law allows a nurse practitioner or physician's assistant in this case, it doesn't even address, other than physicians, being involved in the good faith exam and recommendations. So perhaps at some point we need to get that cleared up as well. Because if it's assumed they can, that's going to open the floodgates to doing exactly what you just indicated, that you get a PA or a nurse practitioner or even an RN basically doing an exam and then somebody Skyping the physician and saying, I make that recommendation.
And again, that would go to, if we got a complaint about that, it would come to the expert to see if that was a appropriate prior exam from that physician, because that physician wasn't doing the examination.
Right, and can you
wasn't
clarify,
involved in
because
it.
it's, excuse me, it sounded like as if that during an administrative hearing, this issue, because you actually do put a pamphlet out about rules and regulations concerning medical marijuana.
This is posted on our website, so.
Right. My students use it in class. But what I'm asking, what was raised in the administrative hearing that caused the concern?
It was brought up to us that it was, that our records did show that it was in person. However, if you look at the law, it's not stated that it has to be in person. But that's what our guidelines was saying, and that does not comport with the law that's currently stated.
My understanding is the inference, and we've had some cases, my understanding the inference is that because there is a requirement for physicians to make a good faith exam whenever they make a recommendation or prescription for medication, that's where the inference was made that you had to have a good faith exam before you could make
You do have to have an appropriate prior examination. That's what the law requires. That's what the law actually states before doing anything. And we would treat for everything, for any type of prescription, whether it was a prescription for Vicodin, for an antibiotic, or for whatever.
So why are we limiting it and discussing telemedicine period at all? Why is that part of the discussion here?
It isn't, and that's why we're taking this out, to only state that it would be an appropriate prior examination and meet the standard of care.
Oh, that would clarify it then.
And that's exactly, if you look on page 5-3, that's exactly the language that we're putting in, because that is what the law states.
And I will add to Dr. Krause, Long Beach was actually disincorporated in 1896 because over alcohol, and then the way they got incorporated was to pass an ordinance that said you could have alcohol if a doctor wrote a letter.
That's Long Beach.
Or if you had a hotel less than 15 beds, and most of the city council members owned a hotel less than 15 beds, so, yes.
Dr. Krause.
It occurs to me that after we move and accept this modification, that I would also like to see this board take a position with a subsequent motion that would move to establish a board policy requesting legislation that would require in-person examinations for marijuana recommendations.
So we have tomorrow, under 21B, we will have Ms. Simoes up here talking about legislative proposals, and I believe that we can definitely bring that forward to you at that time under that correct agenda item, and we'll push that, see how the board feels about that motion.
I'll make a motion if you care for.
We have public comment from the audience. Dr. Sharon Levine, please. Board member.
She can't talk unless if you.
I think she can do that.
Or 6, she can, as long as we don't have a quorum of members in
She
the room.
can not if we have a quorum. I'm willing to leave.
A board member can address the board if
I'm happy to walk out so you can have.
You don't get to leave.
Dr. Bishop, you get to leave. He's not on the committee.
Sharon Levine, board member, speaking in my role as board pedant. There are some other language issues, I think, that would be great to clean up if we're going to do this. The first is under the paragraph, these accepted standards are reasonable, are the same as any reasonable, prudent physician. The 6 things.
What page are you on?
Page 2.
Okay.
Number 3, provision of informed consent, including discussion of side effects. I believe informed consent is a term of law, and I think that it should say is provision of appropriate consent, including discussion of side effects. In the next paragraph, the second line, as they would recommending or approving a medication. Marijuana is not a medication, and so that any other implies that it is a medication.
Right, okay.
So I think that should be changed. And again, the first paragraph on page 3, the physician must determine that the risk-benefit ratio of marijuana is as good or better than other treatment options. Again, so not implying that marijuana is a medication. Great, thank you.
Okay, thank you.
Do you want to also consider adding, I mean, we're not going to wordsmith, but the idea being that in conjunction with discussion with patients, in that last paragraph that you were mentioning? I mean, if we're going to get to wordsmithing on this, I mean, I've got some additional things, but we can talk about it afterward.
Well, we would have to have that change.
Okay, well,
because
okay, so
this is
if we're going to
posted
do
in
the,
board policy.
okay. So,
Go ahead and.
okay, so within the
with your
accepted
changes.
standards and the same, if any reasonable, okay?
What sentence?
5.2.
5.2?
Proper record, number 6, proper record keeping and maintenance thereof. What we find, that's what's lacking in these standalone questionable entities. In number 5 on page 5.3, a physician who is not the primary treating physician, somewhere I put "and in conjunction with discussions with patient." I apologize. I have my notes and I don't remember why, but I've written them in. Thank you.
I think that's covered by 3. In order to provide consent and discussion of side effects, I think that takes care of the in conjunction with patients issue.
Okay. And the good faith of any exam, there's number 5, a physician who is not the primary treating physician may still recommend marijuana for medical use for patients' symptoms, as long as, but again, I just want to make sure that there's that good faith exam, there's the maintenance of medical records, there's a follow-up treatment plan, and that it's always listed, so it's in everybody's face. And Dr. Krause, I want to thank you for your recommendation, because if you hadn't done that, I have to believe that if we cannot get the legislature to pass it, we can get the legislature to pass it. When they realize what's going on in their own communities, we have to do this.
Well, we're not.
Well, I would like to be participatory in helping that out.
It's.
I don't know that we actually have a motion on the floor. And absent that, I would move approval of the statement with the language modifications suggested by Drs. Levine and Ms. Yaroslavsky.
I would second that motion.
Okay. We have any more public comment, either in the audience or on the phone?
No comments on the phone line.
Okay, so we have a motion and we have a second. All in favor of the motion?
Aye.
Aye.
Opposed? Abstain? The motion carries. Thank you very much. Okay, we're keeping pace. Exactly. So I'm glad you're sitting right next to me. So, okay, so now we move on to agenda item number 6, which is a presentation on the Physician Assessment and Clinical Education Program, PACE. Today we have with us Dr. William Norcross, the director of UC San Diego PACE program, and Kate Steipel, I guess I got that right, administrative director of the Phase 2 program, part of PACE, and Peter Bohl, who is the associate director of the PACE program. Their bios are in your packets. You can read them at your leisure. And I would ask Mr. Bohl, Dr. Norcross, if he is here, or Ms. Steipel to proceed with your presentation. Thank you very much for coming.
Thank you for having us, and sorry to inform you, but Dr. Norcross is not here. He had to attend a funeral today, so.
Oh, okay.
Yeah, so
It's okay.
Yeah.
Hopefully not.
You'll cover. part.
Okay, so we were asked to come here today to talk a little bit about a proposed redesigned assessment that we've been envisioning for the past year and are moving closer towards making a reality. And we've entered into some language, or I had worked previously with Susan Cady before she resigned on doing some language updates that would kind of reflect what our new assessment program might look like. And long story short, what we're doing is we're moving from the two-phase program that we have now to a one-phase program where the physician would complete the entire assessment in one foul swoop. So that's what this is going to talk about. And so the reason that we're changing the assessment is because we feel that we've gained a lot of experience and confidence in what we do and know that we can arrive at a decision of a physician's competence in a shorter period of time. And we are certainly sensitive to the amount of time that physicians spend coming to our program and traveling, and are trying to mitigate that as much as possible. And the other reason is that we are also striving to individualize each of our assessments as much as possible so that they're customized to the physician's practice or intended return area of practice. And so, and also while taking into consideration, of course, the reasons for their discipline. And one of the things that came out of the discussions I had with Ms. Cady was that we would be also changing some language. Instead of requiring the assessment to include components that touch on areas that led to their discipline, we may not do that in cases where a physician is no longer doing that. So to go back to an item that's been mentioned several times, an obstetrician gynecologist who is doing cosmetic surgery gets in trouble for cosmetic surgery, and then 4 years later comes to our office, but they haven't done cosmetic surgery in 4 years, and so we may or may not choose to continue to evaluate them. But as such, in the language now, we are required because it's part of the disciplinary guidelines. How is this assessment still going to be the same? Well, our core principles and values remain unchanged. We are here to protect patients and the public at large, and we are here to try to help physicians become better. And that's our goal, and that I'm not going to read you our mission statement. It's there on the screen, and it's in your packets, and it's also on our website. But basically, we have a goal much like the medical boards in public protection, and we will strive to do that. We're just trying to do a better job of what we do and be more efficient. So back to some more specifics. So how is it still the same? We're still going to have always a screening of physical and mental health. We're still going to focus on evaluating physicians in the 6 core competencies of 6 core domains of physician competence that were defined by the American Council of Graduate Medical Education and ABMS, it's the American Board of Medical Specialties. After a physician's completed our assessment, they will still receive a final grade. It's in 3 basic categories: pass, a pass with recommendations, or fail. And where appropriate, we will recommend remedial education. And currently about 40 or 50% do get a recommendation for some kind of remedial education. So how's it going to be different? Well, as I said at the beginning, we're moving from the 2-phase paradigm to now 1 phase. And whereas the assessment currently is 7 days in length, we are trying to move it to about a minimum of 3, but sometimes may take a couple extra days. But our goal is to have it from about 3 to 5 days for each physician. Again, the focus will be on greater tailoring to their area of practice or intended area of practice if they are out of practice. And we will be using some of the tools that are now available to us through the UCSD Center for the Future of Surgery. We have a great simulation center that we have started using in the last year and will continue to do so as the simulation center grows and we become more familiar with what it has to offer. So how do we think this is going to be better? Well, I think importantly for the physicians who come here, it's going to reduce the amount of time that they're out of practice, reducing the travel time, which will save on travel time costs and loss of time in practice. And they will feel that they have received an assessment that is more germane to their area of practice and their specific practice. And I think the way that it's going to be better for the medical board is that it'll be easier to track physicians. You don't have to worry about have they come through phase 1, have they also come through phase 2. The amount of time that it will take us to complete the process will be reduced significantly. And the end result is we will be able to tell you if that physician is competent or if they are unsafe in a shorter period of time. That's it. We were told we had a short period of time. We wanted to leave it very short, and but we're here to answer questions that you might have.
Thank you very much. That was very good. I'm glad you were able to be here for that, because we have new board members, and some of the older board members need a refresher on what you're presenting, and now you have a new format, which sounds very, very interesting, and hopefully will provide us with our needed information. I'm going to ask for comments from our board members first, and then I have a comment, and then from the audience.
So will the cost be reduced as well?
At this point, I don't know for certain. Our goal is to try to make it as cost effective as possible, but the way that the evaluations will be created will be on a per physician basis. We will take into account their background, review a bunch of material, and we will look to see what components of the evaluation will be best for that individual, and that will be how the price will be created. And I mean, the range of prices, my general sense is I don't think there will be a significant change in price one way or the other. If anything, it might go down a little bit for some specialties and it might go up for others, depending. The things that will be costly to use are simulation, where you're having to buy cadaver parts and have the OR there available and things like that. But as we become more experienced in using that center, have a better idea of cost, we'll have a better idea. But the range, I think, is right now, I don't expect significant change in cost, but the significance for the physicians who come here is less time out of practice, which is a cost to them, and less travel time. So they're going to save there for sure.
So the issue of the simulation has always been the big opportunity.
Right.
For us as a board, we've had these discussions way back when to try and figure out how to determine competency of the medical practitioner. And I want to thank you for bringing this full circle to now evolving a whole new program by which we will know that the competency is much. We could never put a practice monitor really in an OR in a hospital for insurance reasons. So to check on the competency and the remediation tools you've offered and you've given us that, I want to thank you for that.
Thank you. By the way, that's a picture of UCSD's future for the Center of Surgery. So that's what it looks like, an OR. And they've.
Dr. Krause.
Thank you for coming today. I'm still learning about all of the components of the board, and PACE is new to me, and I've learned from your presentation. Is your program used by other state boards, or does each state have its own PACE program?
No, there are approximately a handful of programs that do physician competency assessments in the United States, and they're few and far between. But we do receive about 50 to 60% of all of our evaluations from the Medical Board of California, another 20% from other state medical boards, and then 30% that would be comprised of hospitals, medical groups, attorneys, and self-referrals.
Yeah, I have some comments. I'm with the CDCR, so we do refer some of our doctors to PACE. But I have a question about outcome data, because we see they go through PACE and they pass. And do you ever look at down the road what happens? What did you change?
Yeah, I'd say that's the holy grail of what we would like to do, and I would ask the same question of residency programs that graduate their physicians to look at the outcomes. It's an important task. It's one that we have not figured out how to crack, though. We don't know how to crack yet, and I would say one marker could be low recidivism rates of physicians who come through our program, that's of course a weak marker. And I don't know, is that just the fact that because of the sanctions that they received, they are now acting as better physicians, or is it there's just too few resources to fully evaluate or keep a handle on what these physicians are doing in practice? But either way, this is an important idea that we've always wanted to be able to look at and haven't figured out how to successfully do that.
Mm-hmm. And I see here you have a category pass with recommendations. Is it the recommendations that you will provide the additional remediation or recommendations, or you just give it back to us and then we have to figure out what that is?
We've always made a point to try to provide recommendations that can be achieved and not, esoteric and impossible for the physician to fulfill or for the board to be able to enforce. We've really made a point to work with the board on finding ways to make recommendations that can be enforced and the doctors can achieve. And the way that's different from what we're doing now is we've used phase 2 to provide some of the education while they're here. So the difference for us now is that we're going to be putting more effort on the front end of designing an assessment based on additional materials that we'll collect and asking questions about their practice and reviewing, so that we put that in the evaluation. But we will still have recommendations for education. We are not going to self-refer and require them to come back to our program. But if they would like to, we can put up custom programs. Those will be expensive, and that's why we're not going to self-refer for them. Mm-hmm. But if we have programs, or if they have, if we have a recommendation for a very specific area of medicine that might be hard to find otherwise, they could come to us, and that might help solve their problem, but they certainly aren't required to, and that was the goal for us, not to have it appear as though we're recommending they all return for some additional program.
Are there any other comments from members of the board? Any comments from members in the audience or on the, yes, please, did you fill out a speaker slip?
No.
Okay, please, after you finish, make sure you do for us, would you, for the record? Thank you very much. You can have a...
Yes.
Yeah, thanks for your presentation. As a matter of fact, I'm a PACE graduate.
Okay.
I finished the PACE program in 2008.
Ask him to come to the mic.
It's better, if you could come to the mic, identify yourself,
okay,
where you're located, and so we can get it, so everybody can hear, including people on the teleconference, okay?
Okay.
Thank you very much.
I'm Dr. Anthony Jackson. I'm a PACE graduate from 2008, and I have some global concerns and actually fears regarding my experience of PACE. First of all, the cost is cost prohibitive, $15,000 for a general practitioner. Secondly, I finished medical school in 1975. And I was floored when one of the PACE exams was literally part 3 of the National Medical Board of Examiners. And I'd like to know, is there any weight given to a physician who graduated 30-some years ago, who has to take and pass PACE? I mean, just imagine, what if an attorney 30 years after graduating from law school had to take the bar again? Is there some weighted given to those kind of situations? And last and most of all, I remember one of the questions for the general knowledge, the psychological evaluation. You know what the question was? The question was, who wrote the Faust? And the examiner was shocked and awed when I answered, Goethe. Now tell me, for part of a psychological exam, what type of relevance do those kind of questions have? And lastly, the use of PACE by the medical board. It's my understanding that PACE is first and formally to be used for competency and quality care assessments. But yet the board has been known to require physicians to take PACE for getting behind or delinquent in their taxes, or for a DUI that was overturned. And I believe Judge Farley from the Sacramento Superior Court has chastised the board in the past for this use or misuse of PACE. What's PACE's position with regards to these type of problems?
Well,
Dr. Jackson, are you?
It's not,
Yeah.
it's not a question answer.
that's not.
Thank you, Dr. Jackson, for your comments, okay? I think if you could briefly, within a few seconds, a couple, 30 seconds, just briefly address where you are now versus where you were, we could, some conclusion, that would be helpful.
Sure.
Briefly.
The first point would be the general practitioner's cost today is $12,500, not $15,000. I don't know what it was when he came at the time. Either way, we do realize expense is a big reason that it's hard for physicians to come, and we're hopeful that this new arrangement will save money for physicians. With regard to the Faust comment, I have no idea. Oh, sorry, just our presentation. Yeah. Again, just to summarize, our goal is to become more efficient in what we do, make it take less time to determine competence, and hopefully, decrease the amount of time it takes for physicians out of their practice to come.
Thank you very much. And if you will maybe remain after we adjourn, there might be other questions, maybe from board members, other people. That would be great.
Okay. Sure.
Okay, thank you very much for your presentation. I appreciate it. Okay, now we move on to agenda item number 7, which is the presentation discussion on utilization review. Ms. Carrasco, please come to the speakers table. Thank you very much.
Good afternoon. In April 2013, staff made a presentation before the Enforcement Committee on how the board processes complaints involving physicians who conduct utilization reviews. It has always been the board's position that performing utilization reviews is considered to be the practice of medicine. However, the Central Complaint Unit routinely referred these complaints to either the Department of Industrial Relations, Division of Workers' Compensation, or the Department of Insurance to address the patient's appeal of the decision made by the physician performing a utilization review. The Enforcement Committee felt it was appropriate for the medical board to review complaints regarding utilization review, and a change in protocol was implemented in May of 2013. I'd like to report the findings after the board's evaluation of utilization review complaints. For approximately 18 months, during this time period, the board received a total of 40 complaints regarding the physicians performing utilization review. The Central Complaint Unit typically receives 7,500 complaints in a year, so this complaint type represents a small subset of complaints received. Complaints received about utilization review fell into 2 general categories: those performed in connection to workers' compensation claim and those performed by insurance companies. When a case involves workers' compensation, by law, a utilization review must be used to decide whether or not to approve medical treatment. The patient's case is reviewed by the claims administrator to ensure that the treatment recommended by the physician is medically necessary.
I can go dance.
However, a decision to deny, modify, or change the patient's treatment can only be made by a physician who understands the type of injury or illness the patient may have and the treatment being recommended. If the patient or his or her representative disagrees with the outcome of the utilization review, then the independent medical review can be requested. As you can see, 61% of the complaints received related to workers' compensation cases pertain to allegations involving quality of care. Board staff contacted the Department of Industrial Relations, Division of Workers' Compensation to gain a better understanding of their utilization review process and found the following. Treatment standards are defined in regulation. There is no requirement that utilization review physicians be licensed in California. California Code of Regulation, Chapter 4.5, Section 9792.6V allows the Division of Workers' Compensation to utilize physicians licensed in any state or the District of Columbia to conduct the utilization review. Insurance companies review the recommended treatment, for a patient. If the treatment is denied because the insurer determined the treatment is not medically necessary or was experimental, the patient is first referred to their medical insurance's grievance process. If the insurance company upholds its decision or is delayed in responding to the appeal and grievance, the patient or his or her representative may request an independent medical review through the Department of Insurance. Only decisions regarding a disputed health care service related to the practice of medicine not involving coverage issue are qualified for the independent medical review program. According to the analysis performed by staff, 50% of the complaints received in the Central Complaint Unit related to the insurance company cases pertain to allegations involving quality of care. The Division of Workers' Compensation with the Department of Industrial Relations and the California Department of Insurance utilize an independent medical review performed by a physician to determine if treatment being recommended is medically necessary and or whether an appeal will be approved or denied. Both agencies provide a process when a decision to deny, modify, or change a patient's treatment is appealed. The person who receives a letter of denial in most cases also receives instructions on how to appeal the decision. As shown earlier, 58% of the utilization review complaints received allege the review resulted in a decision that impacted the patient's care. The Central Complaint Unit processed these complaints as quality of care issues and attempted to secure any information relevant to the case and had a review performed by the medical consultant. In all cases, the consultant found no evidence that the opinions reached by the reviewer were inappropriate or outside the standard of care. Staff is suggesting that the board continue performing preliminary analysis of complaints involving utilization review with emphasis on those related to quality of care. If the case involves a utilization review issue that is not regarding the quality of care provided by a physician, it is suggested that the Central Complaint Unit staff advise the complainant to pursue their concerns through the grievance process or appeal process that is identified in their denial letter. That concludes my presentation. If anybody has any questions.
Are there any questions from members of the board? Ms. Shipsky, please.
I think we were kind of sidebarring a little bit ago. I think the board at some point might need to make a recommendation for legislation to require that physicians in worker comp review have to be licensed in California. I know I've represented physicians who are having great difficulty sometimes getting paid for taking care of these patients, and the difficulty is that it's been a nurse reviewer locally who has said no. And then when the review comes, it's from a physician that either is not in the same specialty or they're out of state. And so the frustration, both for the provider and I think for the patient, is there is no recourse. I mean, it's very difficult. I know the workers' comp board says go to them, but there's no recourse. And some of these utilization review companies just automatically deny a request for care and treatment because they figure that it will wear down the person. So I'm hopeful. I know that in managed care, you have to have, I believe the physician has to be licensed in California and has to be of the same specialty when they review a claim and deny it. So is there any way we as a board can make a recommendation that the physician who does utilization review for workers' comp?
There has been attempts, and they've been vetoed, so...
We tried again on the basis that it would be protective of both the providers.
I can tell you there have been two attempts under two different governors. They've both been vetoed, and Ms. Mose can also elaborate on that, but we've tried.
Well, we should try again, because this is really a difficult situation.
Yeah. And the board has supported both the bills that were vetoed. We've been supportive of any measure that comes through like that, so.
Okay. We can find a good sponsor.
Any more board member comments? No? Comments from the audience? I have Mr. Steve Catolica. I got that right. Welcome. You can state your name again and the place from where you come.
Yes, my name is Steve Katolika. It's my privilege to be the Director of Government Relations for the California Neurology Society, the California Society of Physical Medicine and Rehab, and the California Society of Industrial Medicine and Surgery. We were the sponsors of those 3 bills that were vetoed, and we appreciated at the time the support of the board, and we would seek it again. We have not given up that issue. It was an administrative decision on the part of the Division of Workers' Compensation to interpret the ambiguity in the law to essentially pass on the physician's licensure and where it should be. But that's really the nature of part of the questions, but that's not why I'm here.
So that doesn't go against his 3 minutes?
Yeah, right.
Yeah, thank you.
Right.
As a matter of
Reverse
fact,
time.
I will guarantee you that's going to go off. In 2013, we were, I think, helpful in clarifying for the board that the complaint that Henry Pereira, Assemblyman Henry Pereira, forwarded, asked you about and asked the questions about, was actually not about the process of deciding medical necessity, but because the injured worker was actually harmed. And that was the turning point. All those statistics have nothing to do with harm. We're here to say that we believe that there's some education that needs to be done, and we as organizations are attempting to do that and will continue to educate the patient population as well as the physicians and those occasional attorneys that end up being in the mix somewhere, that it's not the process. You folks cannot do anything about the process, as flawed as it is, but rather that you need to be able to discern when harm has taken place, and they need to communicate to you that that's the case. There's one that you're going to get a complaint, and I know that you've gotten several, but I know that you're going to get a complaint about an authorization for a spinal injection that included authorization for the procedure, included authorization for the radiological component, but did not authorize the IV sedation that sometimes needs to go along with it. And the surgeon was not able to provide that care, because when they get the person on the table, if they're anxious and need help, they're going to need to sedate the person, and yet they could not. That injured worker was harmed to the point where they needed care subsequent to that process that they should not have had to experience. That's what needs to be communicated in the complaints. We understand that. I don't think the public does as well as they should. And so we're here, as I said, to tell you that we're going to do everything we can for that education process. But please, in the meantime, do not dismiss what's being given to you as simply complaints about the process, because it's easy to complain about the UR and IMR process. We're convinced, and there's a case going up, that in fact the IMR process, the way that it's in labor code now, is
Your time is up.
Unconstitutional. So we will be working with you. Please don't turn a blind eye to this. Thank you.
Thank you very much for your comments. Appreciate it. Any comments from members or people on the phone, teleconference? Anybody?
Yes, we do.
Okay. Please state your name.
It's for Dr. Kadisha Lang with the National Medical Association. Please go ahead.
Okay, Dr. Lang, go ahead. We can't hear you, Dr. Lang.
Okay, can you hear me now?
We can hear you now. Go ahead.
Okay, thank you. I apologize, the timing of this is a little bit late. I was trying to get in right after the discussion on the PACE program, and I just wanted to put it to your attention that if the genuine object of the board and the PACE program is to try to help re-educate physicians to give better education and know how to properly take care of patients if they have been found to be insufficient or inadequate in some area as a result of their interaction with the board. I think that something that should be looked into is having a part of our medical fees that we pay to be licensed include the cost of a PACE program, because the cost, once again, is quite prohibitive. The cost of attending a PACE program when a physician is recommended to go there as a part of their settlement can run, I'm told now that it's running between $5,000 to $12,000, in some cases more, plus they've got to leave their city, they've got to pay for housing and food and all those things while they're at the program. So I'm thinking that perhaps something that should be done in order to make it more accessible for physicians to have that as an option to consider is make that a covered cost. We are paying licensing fees every year. Let the cost of that program, if it's really going to try to benefit patients by improving the quality of their physicians, let that be included in our licensing fees, because the cost is prohibitive for many people.
Okay, thank you very much, Dr. Lang. Appreciate it. And let you know that the staff from PACE is in the room. Okay, moving on to agenda item number 8, and there is going to be an update of the transition of staff to the Department of Consumer Affairs. Mr. Gomez, welcome back. It's always nice to see you.
Good afternoon, Chairman Lewis and members of the Enforcement Committee of the Medical Board of California. I'm Michael Gomez, Deputy Director for the Division of Investigation Enforcement Programs for the Department of Consumer Affairs. I want to give you an update today on the transition of the Medical Board investigators to the newly created Health Quality Investigations Unit of the Division of Investigation. We are now through the first quarter of that timeline of July 1st, and I'm pleased again to tell you that it has gone very smoothly, and with the help of Kim Kirkmeyer, the Department of Consumer Affairs continues to review the budgets, review and have discussions with your executive director regarding costs, if you will, as this transition is going forward. And so we're sharing that information where unfinished business has not been concluded. We try to resolve those as soon as possible. And to Kim, she's got a pretty good eye on the budget. An example that we had recently was the coding of rent space, and a couple of our field officers, you were being charged for it, and it should have been us being charged for it. In the personnel area, I wanted to tell everybody that I take great interest in our staff, and on August 8th, the director and I and the chief deputy director held a all supervisor meeting for all HQIU leadership team members to hear and discuss concerns they had or challenges they may be seeing that they could share with us, and it went very well. I think it implanted in the executive office not only the importance of our work, but the dedication of the employees of the Health Quality Investigations Unit for the Department of Consumer Affairs. In time, we have also tried to make the issue of equity on the Investigation and Enforcement Unit side and the HQIU side, now former medical board employees, so that the equipment issues are resolved and there is equity in the operations, if you will, in terms of equal treatment across the board. So, Ms. Yaroslavsky, I mean, I think I mentioned to you last board meeting that the vehicles will be in for the supervising investigators for HQIU at the end of this month, and to also notify the enforcement committee that we've had some new technology improvements coming to HQIU as well. In March of this year, the California Department of Justice approved the Division of Investigation to have mobile access to the California Law Enforcement Telecommunications System. So we will be buying and providing to all the investigators on the HQIU side mobile access, wireless access now to the to CLETS, which is a wonderful tool in the field investigation. As you can probably visualize, that it's no different than that terminal you'll see in a patrol car. Mobile data terminal, and that is what we're beginning to share with the HQIU investigators and our peace officers. As stated in the previous meetings, I want to provide this board and the enforcement committee with data and comparable data in terms of the improvements that we are attempting to make and looking at case aging across the board. I have some rough numbers that don't give me any great concern. We seem to have a little bit of a bubble approaching the year cases, but that, as I said, is our rough numbers, because I cannot run reports out of breeze right now. We are attempting to correct what's called the E229 report. We have some logic and behavior patterns that aren't accurate reflecting what those numbers should look like when we compare them with actual figures in the field. So there are some behavior issues that we are reconciling with Breeze to get those reports corrected. And I know that Kim and I have had the same issue regarding the standardization of those reports. But I'm confident we'll get there in standardizing those reports. In the rough data that I have looked at, and just to remind the Enforcement Committee that we are using Excel spreadsheets at each district office to track the case aging by investigator, by district office. So we know that what the numbers look like. The problem is that the stats that I have today are the stats that were compiled at the end of last month. So they're 23 days old. But in looking at them, there is no major increase in the case aging when I look at all the sequential data points of 1,900, 800, 700, 600, 550 days, et cetera. There's a small bubble in the 365 year old, but we have instituted a goal now to look at those 365-year-old cases and instituted case aging councils at each field office. Chief Threadgill and retired annuitant, your former Deputy Chief of Enforcement, Laura Sweet, are now going out to the field and are going to reinstitute those case aging and those case reviews so that we're on top of that. Regardless of the reporting data that we have, we can get in Breeze, we want to make sure that those case aging issues do not become uncontrollable. But I feel confident that we can do that through the processes that we have in place. So our goal is to decrease that number and begin to look at a report that we can hopefully provide the Enforcement Committee and the Medical Board at our next meeting that maybe is a little more accurate than the dated numbers that I have. I also want to give you an update on VE. Regarding the VE program, at the last board meeting, I reported that the Division of Investigation was following the 2011 July 2011 version of the Vertical Enforcement Manual that was agreed upon by the Medical Board of California and the Attorney General's Office. And I also reported, Ms. Yaroslavsky, if you recall, that we were going to have some meetings, and those meetings have occurred. We've had 3 meetings to date. The meetings are structured. We have agreed upon agendas. We have actually completed an initial draft of the first, what I would call the first stages of the Vertical Enforcement Manual that relate to the definitions of vertical enforcement under the government code, the vertical enforcement team, and we've added a new component in there regarding the VE team as it relates to the medical consultants. The medical consultants prior were not included as defined team members in the vertical enforcement manual. We are looking at, we've just have agreed upon, I believe, on the disagreement resolution, but we still have a ways to go. Our next meeting is next Wednesday. We're meeting hereafter every 2 weeks and hope to have a final product or a final draft by the second week in December. I'm very confident in the process that we are following, that we literally have put everything on the table, so we can glean from lessons learned, what we've experienced, what we're seeing, if there are efficiencies or there are better ways to do business in terms of our partnership with the Attorney General's office, with the case aging and the roles of the investigator, the roles of the prosecutor, if you will, and also the timetables that we should be looking at in terms of the respective roles in this VE process. The last thing I want to, because I know time is short for the committee, is that I am extremely pleased with the transition and the way it has gone. I'm also very supportive of the process that we're using. You know, our VE manual work group consists of your executive director, myself, the director of our department, our chief deputy director, our legal counsel, and Deputy Chief Laura Sweet, and Senior Assistant Attorney General Gloria Castro and her staff. So we have a lot of good minds that are working on this, and we have, I thank Gloria for being open for all these discussions, and we're looking forward to completing this process as soon as possible. If there's any questions, I'm pleased to answer those.
Okay, thank you very much for the presentation.
Wait a second.
No, I'm getting on to you, but any comments from members in the audience? any comments from members on the teleconference? Telephone?
No callers in queue.
Okay, now comments from members of the board, of the committee. Go ahead, Ms. Yaroslavsky.
So, Mike, I have a few questions. Sure. We heard a whole lot, but we heard a whole lot of, I'm not sure what we heard a whole lot about. My concern is that Breeze is still not, you're not able to access Breeze. Do you have a date time frame when that's going to be working?
Kim, correct me if I'm wrong. We talking December? I think that's what the Breeze user group came to, that the modifications to that report would, yeah. Right.
That report doesn't work for your statistics. So,
It's in your report, too.
It is. It's in my report. I was just notified actually yesterday that our staff who have been working on these reports, their information that they are working on, the database that they have been using, unfortunately, we may have some issues with them using it. We're working with the department right now to see if we can get in to get the information. We've been working on these reports. We hope to have them by the end of the year is what I believe in my report. And that's, unfortunately, everything that we look at has to go back in almost and be manually touched in order to bring the information up to where we can even run the reports. So that's kind of what we're looking at. The report that Mike's talking about, the E229, we were able to run some reports, some preliminary ones, and then take it from what the E229 report was and then turn it into how we would normally do it, because the 229 isn't the way we've used it for our reporting. And we actually, Mike is right, it is actually at the end of last fiscal year, the number that was at the end of last fiscal year was 245 days, and for the first quarter was 235. Now, I cannot sit here and say with 100% assurance that those are the accurate numbers, because we still are working out to verify those numbers, but I can give you that number. It was 245 at the end of last fiscal year and 235 at the end of this first quarter.
So that's an improvement. Yes. So the next thing is that the Excel spreadsheets that are going on now in the office, that will give you a better definition of the timeline and the timeframes to make sure that that's happening?
It is, yes. It's a great management tool for us to do that. When we look at the individual investigator workload and the investigator time cycles, we have a pretty good handle on that. The issue is, when I'm in Sacramento, I can't grab that at a moment's instance because they're spreadsheets. They're only for the time at the end of the month which we compile them. So that's why we're sending Renee and Laura Sweet out to the field so that we can be on top of those cases. So we're looking at those case reviews, those case review councils, and that we begin to look at sending reports that back to the field when we see the bubbles approaching 365 days, we need to notify.
You're catching them.
We have to, because if we don't, what happens is we have bubbles. We have volume bubbles that if you don't catch them earlier on, you're going to be caught off guard. And we need to catch those as soon as possible.
So what I'm looking for is just the last thing I would like to ask you is, in the past, when you didn't have this oversight, right, we were able to hold our staff's feet to the fire. Mm-hmm. They reported to us automatically. We knew exactly what we were asking questions about. We had the information at our fingertips. Right. You've given us a report, but I haven't heard anything that, other than we have a few bubbles.
Well, I can tell you
what is a good report going to sound like from you, and what is a poor report going to sound like? What do we need to be worried about that I'm not going to, I want to make sure we're not reading about it in the front page of the newspaper, that we're holding up stuff.
I think there's two things. That those priority cases, those cases when we're working with the Attorney General's office, those PC-23s or those ISO cases, that those aren't recognized at the front end as urgent cases. Those are things that are going to hit the paper. Those are not case aging per se, but they're public safety issues. The second issue is that when we start seeing cases that should have moved along efficiently and we're not on top of it, and we should have been on top of it, I think those are the things that get in the paper as well. But we look at the category of those cases. We look at the, if you will, the priority of those cases as well, and working with the AG's office and the lead prosecutor, try to develop, what comes first. But I wanted to do this. I want to tell you that in assessing the raw numbers and assessing the numbers we have put together, I can tell you about pre- and post-transition levels of production. In comparing the first quarter of fiscal year 13-14 with the first quarter of the fiscal year, I noted there have been 74 fewer cases assigned to the field. This is largely attributable, I believe, to the implementation of the non-sworn complaint unit, which is now as part of the Consumer Protection Enforcement Initiative, the non-sworn unit that now resides at the medical board, which now handles the less complex 801 cases. Okay, so those 801 cases aren't coming to HQIU, I believe. As for cases closed last year, we had 208 cases that were closed as of October 1st. This year, 203 cases have been closed. Last year, 19 cases have been referred for citation and fine or public letters of reprimand, and this year, 20 cases have been referred. So last year, 19, I'm giving you kind of a summary of what I put
Workload is
together.
Similar? What you're telling me is the workload is pretty similar?
It's similar, but one of the things that...
Improving or similar and not improving?
I think there's some improvements, but one of the mitigators in that is that this is the year of retirements. Again, for the peace officers, we're losing. We just lost Laura Sweet. John Harai, the Soup 2 out of South, is retiring December 30th. Marianne Eckhoff is retiring December 30th. And we've had people leaving to other agencies as well. So we do have a vacancy rate that I can see there's a bubble. And so that's why we're trying to catch these 365 case aging issues early on.
Mr. Gomez, let me move on for just a couple of pertinent questions. The timeline between the HQES and the HQIU, that timeline we don't know. That's a part of this puzzle, this equation between the two. Right. And I don't hear that part.
And that part is the discussion that Gloria and I have had regarding the how do we my count versus AG's count.
Right.
And so how do we matriculate the data between the two agencies? Because I just explained that I'm putting together spreadsheets at the end of the month.
So maybe you'd need to take a date, and as of that date, even if it's not this month, maybe it's 3 months ago, maybe you need to come up with a date that you're going to have consistent on both sides, that you can compare real and get to where Dr. Lewis is going.
Yeah, because we have no control over that.
Right.
But that's a big part of when we get the information back to the medical board. That's the time.
Right, and that is one of the concerns that I think that when you look at the administrative justice system, that when you look at the cycle times from the intake to the investigative stage to the referrals to what I call the adjudication system, there is some disconnect there.
Yeah, there is. Okay. Yeah.
Dr. Lewis, I just want to let the members know that it really all rolls back to the fact that we can't get reports out of Breeze that we need, because everything that we would need to compare to what Ms. Castro has are the reports that we need to get out of Breeze. I've asked for, as of November 1st, the pending cases that are at the AG's office, so I'm going to see if this is able to be achievable. I think with what happened yesterday, that may impact me getting that, but I'm hopeful that the department understands the importance of these reports to us and will assist us in getting those. And so that's really where everything for poor Mr. Gomez, as well as you as board members and our executive staff, it all hinges on those reports, and that's what we're trying to get. So. And
the production releases for these were supposed to have been almost completed in November, right? Mm-hmm. Are you on track with the production releases for Breeze? I
think we pretty much. Are
you done with those?
The issue that I have seen is the standardization issue of the reports.
Right.
I think the standardization issue, which we are addressing, we're working through that. We're trying to get that completed by December. Okay, but go ahead, Kim.
Those changes that are going to be made are not the ones that we need for our reports, because again, we're the ones working on our reports at the staff at medical board. So the changes that are being made in Breeze are more for the production part of Breeze. It's not for the reports.
Not for the reporting part, okay.
There's the one report that they're working on, but other than that, that's it.
I think next time if we could see numbers on a piece of paper.
I would agree.
Yeah, that would be very
so helpful.
We're going to attempt to do that, through hook or crook. We're going to try to do that. I mean, we have, in the field, we have our own case management information. It's just not live in terms of what you need.
But it can even be rough that you produce, because some of us are very visual.
No, I get you,
versus
Doctor.
auditory.
I
So
get you.
me. Okay, thank you. Any other quick comments or thank you very much. We'll see you at the next
One
meeting.
thing, Dr. Lewis,
Okay.
I do want to just inform the Enforcement Committee that the department does and still continues to invest very seriously in the BREEZE project. We are working to correct a lot of these, and there's a lot of lessons learned in this. It's a huge project, and we are committed to making it work, and I have been directed to attempt to get these enforcement reports corrected for the purposes that I need them for in the boards. Okay.
Well, we don't envy you. So,
good job.
Thank you very much for your report, and we will see you at our next meeting, I'm sure.
I know you're visual.
Yes, visual, please. Thank you very much.
I am as well, Mr. Gomez. It would make my
Yes,
life a lot
she is
easier to
as
see
well.
something on paper.
Yes.
Yes, right. Okay, thank you, Mr. Gomez. So now we move on to Agenda Item 9. I know we are well over our time allotted, so we really have to move on very quickly. The next is disciplinary action demographics. Ms. Kirschmeyer and Ms. Robinson are now presented at the speaker's table. Thank you.
Okay, we'll try to make this quick. At 2 prior board meetings, we actually had public comment stating that there were racial differences in the board's disciplinary action. The implication was that certain individuals received more discipline or more significant discipline than others. In order to determine if these allegations had basis, the board staff looked into this issue. Before I have Ms. Robinson go over the chart and the information that has been gathered, I would like to just discuss some information that is important in the process. It is important to point out that the board only takes action on complaints that we receive or that the board otherwise becomes aware of a violation. The board receives complaints from a number of venues, including patients, patients' families, licensees, other state or federal agencies, mandated reporting, newspaper articles, law enforcement, and industry associations. From time to time, during an investigation against another physician, the board may be alerted to possible violations by another physician and may open a complaint. In addition, during the course of an investigation, the board may identify other patients who had civil cases against them, against the physician being investigated, and may open a new complaint on that patient. However, outside of this, the board does not randomly or with cause go out and inspect a physician's office and look for complaints. The board cannot review a patient's records without authorization or subpoena, which would require authorization via good cause, and therefore such inspections would not be a good use of the board's resources. Other state agencies, such as the Department of Healthcare Services that oversee Medi-Cal, can do this. However, the board cannot. The other issue that needs to be discussed is that the board does not know the ethnic or cultural background of a physician when it first receives a complaint. Out of approximately 7,500 to 8,000 complaints received annually, almost 6,000 of those complaints are closed with no further level of action. Although the board requests ethnic and cultural background information on physicians, this information is listed on the board's licensing system, and staff does not have that information during the complaint review. In addition, a large percentage of physicians do not submit this information to the board, as it is actually optional information. Once an investigation is initiated, the board's investigators would be aware of the physician's ethnic or cultural background, specifically when they interview the physician. However, no action can be taken specifically on quality of care cases unless an expert opines that there was a departure from the standard of care. In addition, the Attorney General's office must agree that there is establishment of a violation that meets the level of clear and convincing evidence. Once that decision is made, the executive director must sign the accusation to pursue disciplinary action. Once the accusation is filed, the matter proceeds to either hearing, stipulation, or default. A final action cannot be taken without the review and approval of the board members, and decisions do not indicate a respondent's ethnic or cultural background. Unless the matter becomes comes to the board through an oral argument hearing and the respondent physically appears before the board, the ethnic or cultural background is unknown to board members. Only a very small percentage of the cases go through the oral argument process. All of this information is important for the board and the public to understand as we proceed to explain the information that has been gathered. I would now like Ms. Robinson to proceed with the findings from the statistics gathered. Ms. Robinson is the board's research program specialist and is the one that deals with all of our data at the board.
Thank you, Kim. Good afternoon, Chair and members. Please refer to pages 9-1 and 9-2. 9-2 was just added. I think Paulette probably brought it around. It was posted on the board's website, and there's also copies in the back. This information is regarding the ethnic background data that's being provided. The data shown on these charts were gathered by the board's enforcement data and the board's physician surveys. If you'll refer to 9-1, the ethnic background data displays the complaints, investigations, and discipline for the 3 fiscal years 10-11, 11-12, and 12-13. With regard to the ethnic background, the percentages shown, for example, in ethnic background that is other ethnicity, moving from left to right with the fiscal year 10-11 starting, there was 4.3% complaints. In 11-12, there was 4.5% complaints. And in fiscal year 12-13, there was 4.5% complaints. And that's complaints based on the total number of complaints that were closed. If you look at the same ethnic background for other with regard to investigations for those fiscal years, they're 4.1%, 3.9%, and 4.5% respectively. The discipline for those fiscal years shown for that other ethnicity show 2.3%, 4.6%, and 3.9%. With regard to the chart on 9-2, we actually took the other ethnic 3.9% that was shown for discipline only for fiscal year 12-13. And looking at that, it shows the total number of discipline for other ethnicity was 15. That's the grand total. Of that total, there were 4. The penalty imposed, 4 of those were for probation, probationary years 1 through 3. There was also 4 for probation for 4 to 5 years, and there was 1 PLR. There was 2 revocations and 4 surrenders. We only provided the fiscal year 12-13 data because staff just started tracking this in a spreadsheet form. It is very, very labor intense, and I'm so glad staff started doing that. We were able to look at the severity of the imposition and compare it to the enforcement data, put those 2 together, and was able to provide this chart. So moving forward, we will have this data. The number of, so in developing these charts, I consulted subject matter experts to determine how better to go about gathering data to answer the question, is there racial disparities imposing disciplinary actions by the board? From the data on both of these charts, you could see that decline to state, no response, and no survey found shows high percentage of physicians that do not provide their ethnicity on the board survey. For some physicians, they actually indicate multiple ethnicities on the survey, as shown in the charts as multiple entries and multiple answers. Looking at chart 9-2, you'll notice under the decline to state, no response, no survey, for probationary licenses, there's 21, and that's because there's no survey done when you're applying for licensure. As Ms. Kirkmeyer stated earlier, complaints are generated from a variety of sources, and the board only takes actions on complaints the board receives. She also pointed out that the board on very rare occasions may open a new complaint. In conclusion, the data the board was able to provide does not indicate any disparate treatment based on the outcome of investigations and discipline versus complaints. Thank you.
Thank you very much for that very labor-intensive report. Appreciate it very much. I knew it took some time. Thank you. Are there any questions from board members? Dr. Kraus, please.
This is an issue that will never go away and always needs our constant attention. The statistical effort that was taken is admirable, but for those of us who submit scientific publications to journals of peer review, we know that before you can make sense of statistics, you have to do a probability analysis. And I'd like to see at our next meeting the p-values. Because, for example, we can look at odd numbers and we can say, well, there must be some prejudice if of the 4.4% complaints of a particular group, 4.9% ended up in discipline, or if the when the discipline rate is higher than the complaint rate, one has to self-question. But there is random distribution in mathematics and statistics. So all of these numbers need to be looked at with a statistical analysis to look at p-value to say, what is the probability of having this disparity just by random distribution? And if any of these numbers have statistical significance, then we should apply greater attention to them. But there is no doubt that in every place of the world, and even in the United States, that there is bias, there is prejudice, there is racism, and it's not going to go away. And rather than to dismiss a charge, we have to take it upon ourselves to be constantly surveillant. And to do this analysis is an important part of that. So I don't think we should view this as just a way of appeasing people who complain, but it's important for us to be constantly introspective. Each of us sitting in this room individually think that we harbor no prejudice. But each of us sitting in this room think that most of the people in the room have some prejudice. And you always have to question it. Each of us may have been victims, perpetrators, or witnesses of prejudice. So I applaud the people who bring this to our attention and constantly remind us of it. And it's important for us to keep doing this analysis. Thank you.
Dr. Lewis, can I just point out, because I know where Dr. Kraus is coming from, I did want to state that the statistics, you can't state that it's of the 4.4% complaints that got the discipline, because that's each year that those actions were closed. So it could have been the 4.9 was based on complaints that were received earlier. So you can't compare those one-to-one. So it's based on the total discipline that was taken in that year, absent of when the complaint was received. Okay, so I just wanted to point that out for everybody in the everybody that's reviewing it.
Any other comments from members of the committee? No. Did you want to make a comment first?
I know that we have a couple of speakers who want to speak on this topic, and I just wanted to remind the speakers that because this is a subject related to discipline, I want to ask you to not discuss anything related to a case. This is because the board is prohibited by the code from having any information related to a case, any case-specific information, before it is formally before the board. So if you're providing any materials to the board, I'll need to look at those to make sure that there isn't any case-specific information. So I just wanted to generally state that.
Thank you very much for those comments. I have two comments from members of the audience. First one is Ms. Savong Chung from the CMA. Would you come forward, please? Thank you.
Good afternoon, Yvonne Chung, California Medical Association. We just wanted to express our appreciation to the board for putting this data together. As you know, CMA represents, in addition to representing all physicians, we have relationships with subsidiary groups, a lot of ethnic medical organizations, and I think they will find this information to be very helpful. I would encourage the board to continue to do this kind of analysis on complaints. I think it's not just an academic exercise. I think it's a good way to target certain groups for further education. If you start to, even not just by ethnicity, but by geographic area, by specialty, I think this is a really good way, someday when we get the information in Breeze and we can do this more easily, to really start to analyze where your complaints are coming from, where the discipline is happening, and use it as a tool for improvement and helping to address some of these issues before they arise. So I know it's very time intensive, and we really do appreciate staff's work on this. Thank you.
Thank you for your comments, Ms. Chung. The final speaker that I have here is Dr. Anthony Jackson and Dr. Arnold Savage. Would you please come to the speaker's table? Thank you very much. And we have, between the two of you, we have 3 minutes to make comments, so I appreciate you taking
Thank you, Mr. Chairman. And also, I want to thank Dr. Howard Cross for those very culturally sensitive remarks. And also, most of all, I want to thank Madam President, Ms. Kimberly Kirschmeyer, for putting this topic on the agenda to be discussed. It's a quintessential matter that we must address forthwith and honestly. And as you know, we appreciate the statistics. We've provided some data of our own, but I believe it was the late, great Benjamin Disraeli from Great Britain who said, correct me if I'm wrong, he said, there are lies and there are damn lies, and most of all, there are statistics. So Dr. Krause is most certainly on point when he says that we need to see P-points to back up these statistics, because our data tends to indicate that, in fact, Houston, we do have a problem. And with that, I'd like Dr. Arnold Savage, who is the co-minister of health for BAPAC, which is our civil rights organization, to read a letter from its chairman, Mr. Percy Pinckney, who is the president and founder of BAPAC.
Thank you. Indeed, I also concur with Dr. Krause's comments. And I'm going to read a letter from the president of the BAPAC, called Black American Political Action Association of California, Mr. Percy Pinckney. And the board members here have this letter before you. I'll read the rest for the audience. This letter is dated on the 23rd of this month, addressed to Mrs. Kimberly Kirschmeyer. It was also copied to Honorable Anna Cabrillo, Secretary of the Department of Consumer Affairs, Josh Gorbin, who is the Honorable Senior Advisor to the Governor, Alice Hoffman, who's the President of California NAACP, Dr. Anthony Jackson, who sits before here as a Health Minister for BAPAC, and Awad Kadane, I don't know if that name is correct, but Director of Department of Consumer Affairs, and Mr. William Jamal Miller, who's Director of Health Equity. It states that, Mrs. Kirschmeyer, the NAACP and BAPAC are, as you know, California's two largest civil rights organizations. Both groups have received countless complaints for years regarding the medical board's desperate treatment of ethnic minority physicians. Our Minister of Health, Dr. Anthony Jackson, has raised some global concerns in an agenda set for discussion today on today's board's enforcement committee. Empirical data and prima facie evidence has been provided, which indicates that the medical board's disciplinary demographics may provide a nexus for 10 various forms of discrimination. This disproportionately seems to adversely affect Black and Hispanic physicians. This also could cause patient harm. The board's mission is to protect the public from harm. So the BAPAC must ponder the issue. Is this an X factor which accounts for the racial divide between health and healthcare burdens in California. The Honorable Governor Jerry Brown recently created the Office of Health Equity to specifically study such health disparities. So it is my official capacity, in my official capacity as the president of and founder of BAPAC, respectfully must ask, would the Medical Board of California voluntarily agree to participate in a study regarding disparate demographics under the auspices of the Office of Health Equity? Since the Medical Board is also a subsidiary of the Department of Consumer Affairs, BAPAC will ask the Department of Consumer Affairs to also facilitate this study. Thank you for your cooperation. The other part of my statement states basically that in complete alignment with Dr. Cross, we have a lot of data, although this data didn't present with statistical proof about what goes on. And what I think we should do, we do know that things go on that are inappropriate in terms of racial discrimination among all groups. And we should really, this board should really find a means to address the issue of how to reduce the investigators' propensity to have I'm going to give credit, an unconscious bias of how they look at a given problem. And that's what I'd like to propose along with the issue proposed already. Thank you.
Thank you very much, Dr. Savage. Dr. Jackson, do you have any summation of your comments for us?
Yes, I do.
You have time.
More specifically, I would like to ask the board to make a motion to see whether or not they will, pursuant to Mr. Percy Pinckney's request, voluntarily agree to participate in an objective study, all right, that will take a hard look at this data under the auspices of the Office of Health Equity, which the Honorable Jerry Brown created specifically for these type of situations. As Ronald Reagan said, you know, we trust the board and their data and their statistics. However, trust but verify. And we believe that the Office of Health Equity, which was recently authorized under Section 1310195, would be perfect. They specifically have a statistical unit which knows how to analyze this type of data and come out with the whole truth and nothing but the truth. And we think this is what's needed. And until such occurs, there's going to be an ongoing suspicion that black physicians and or possibly Latinos are racially being profiled and being disciplined in a discriminatory and draconian manner. And I think this is something the board needs to address forthwith, once and for all. And we need to ask and answer the question, is this causing patient harm? Because if you look at the morbidity, mortality statistics, you can see that the disparity in health and health care between African Americans and other minorities is way off the Richter scale in comparison to their white counterparts.
Dr. Cross. Does that conclude your comments? Thank you very much. Thank you very much. Dr. Krause.
Before we would make a motion, I would personally, with the board's approval to be determined, request that Ms. Kirkmeyer investigate the suggestion and report back to us with more information before we commit to following that particular pathway. But I think that these are issues that we have to have under constant surveillance, and we can't ignore them.
Yes, I agree. We have ways to look at this information back at the medical board. We're just seeing your proposal and your recommendation first time. So I think, as Dr. Krause says, I think the staff needs to look at this as probably a potential agenda item, and it wouldn't be appropriate to make a motion today when we haven't had a chance to digest it and massage a little bit. So, but thank you for your recommendation. We will take it under advisement. If that's
right.
Okay with
Fair
you.
Enough. Fair enough, and thank you.
Okay, thank you for your comments. Okay. Well, we're coming to the next agenda item, and that is our adjournment. So do I have?
So moved.
Oh, we have a future agenda item. Sorry, I didn't see that. We have future agenda items. I'm out of turn. Are there any comments or suggestions for future agenda items? We We had one. So anybody from the board?
I would like an update from DOJ about our enforcement issues. I would like to hear some statistics. I would like to hear some compare and contrast, and I'd like to see some paper copies of what's going on.
Yes,
both DFI and DOJ, everybody.
Everybody.
I mean, it's been now it'll be 6 months that you guys are in charge. I want to know how we're doing.
I think Mr. Gomez has a standing invitation, I think, right?
Yeah, he knows.
And same as Ms. Castro, they all have standing invitations, so we will
It's
see
no
you
different
again.
than we used to hold our staff to the feet to the fire. Their feet needs to be to the fire as well.
Any other future agenda items for the Enforcement Committee? Seeing none, do I have a motion for an adjournment?
You have so moved.
And remind of the committee that with the Executive Committee will start promptly at 1:30. We have to stay on schedule, and it's 1:20. So we have a motion to adjourn?
Yes, you do. You had it
Yes,
twice.
adjourn.